I'm going to share screen one more time, and then you should be able to see it. Can you all see this? Didn't lose access?
Yes.
Yes.
Okay. Thank you. Play it from the current slide. Cool. All right, so chapter 4. So we ended last week just talking about introductory things. So what's abnormal psych? And then we started to talk about developmental psychopathology, which is more of a framework within abnormal child psychology. And that one is what I recorded last week. And it's really helpful for understanding child psychology, but it's also going to be helpful for your first assignment. So even more of a reason to go back and watch. And then chapter 3 were just additional like domains that we are interested in for developmental psychopathology. So I included things like attachment, social cognition, and temperament. So that's where we ended. And then this week, we're just talking about research in this context. So some of this might be some review for you. So some of this is going to be what are the different study designs that are out there? What are the appropriate steps for coming up with a research question? And what are some of the things we actually look at in terms of research in this area? So review from chapter 2, this is all the developmental psychopathology stuff. This last bullet point is most important for assignment 1. So make sure you're reading or watching from that slide on. This is the stuff I just talked about for chapter 3. So additional domains of interest. So the biological level, the like cognitive learning levels, and then the sociocultural levels. We were supposed to be here on Wednesday, so we're here on Friday now, just catching up. Quick note, the syllabus quiz, which is optional, but is extra credit, is open, but it's going to close this Sunday at 11:59. So if you didn't get a chance and you want to do it, make sure you do it before Sunday. Topics we'll cover, so scientific method, measurement, research design, and then certain ethical issues. So this graphic comes from your book, and these are basically different layers or levels of things that you can ask in developmental psychopathology that we have a lot of research on. So in the center, this is your domain of research in this area. And we like to ask things like how common are these disorders? So what's the prevalence rate, which we talked about last week? How do disorders change over time? So this is touching on continuity and discontinuity, multifinality and equifinality, which was covered in developmental psychopathology lecture. We also ask things like what causes abnormality and what are the underlying mechanisms. So this is looking at what's the etiology. So are there any markers in the genetic context? Is there anything socioculturally that we're noticing that can serve as a risk factor? Are these the mechanisms that abnormal psychology appeared in this individual? Similarly, what puts youth at risk and what protects them. So that kind of goes hand in hand with that other bubble, because here we're really looking at risk factors. So again, what puts this individual at risk for psychopathology and what protects them. So what protective factors do we think are going to buffer the effects of this adverse experience that the child has? Similarly, what demographic factors are associated with specific disorders? So just as we were saying in chapter 1 with how gender might play a role in prevalence rates or how culture or ethnicity or race might have a role, same thing comes into play for specific disorders. So when we talk about ADHD and other externalizing disorders a little bit more in depth, I think in a couple of weeks, we'll talk about how there are gender disparities in who gets diagnosed with conduct disorder, ADHD, any of the externalizing spectrum disorders. So why is it that you have a disproportionate rate of males, but also why is it that there's a certain race that gets disproportionately diagnosed with this disorder? So that's going back to what are the demographic factors that we know play a role in that. How can disorders be treated? So these are what are the interventions that we already have and what are the mechanisms of change that are established and already researched for that intervention? So for all of the disorders we're going to talk about, we'll talk about what the disorder is, what are the diagnostic criteria, a little bit about etiology if there's anything to be said, and then we'll move on to what's the intervention that we know works for this disorder, that we know works for this population. What are some example like worksheets you might use in that intervention or treatment? So what would you be doing in therapy? So for those chapters, when we get to intervention and treatment, I think I've mostly included like what your book says, but also I have like my own like worksheets or like models that I've used in therapy with my own clients. So I'll show some of that. And then how can disorders be prevented? So that's on the prevention effort side. A lot of what we'll talk about is early detection and early intervention. So especially for things like personality disorders in adolescence, that's something that is rarely diagnosed, and yet we know with research that it is something that exists, and that the longer that we push treatment and identification, the more the individual just suffers, or the more the individual um, is able to like cumulatively build risk factors. So how can disorders be prevented? Some of it is like school intervention, some of it is just um, what's the word? Like ex teaching the population or the public of these different things. And the other thing is early detection and being able to treat it early. So for any of those questions that we want to ask, we have to follow, if you're a researcher at least, not necessarily if you're the clinician, but if you're a researcher, we need to follow the scientific method. So this is probably something you've heard in like elementary school and science class. The scientific method in research in the psychology field is exactly the same as in a hard science, like in a chemistry or a biology lab. So we're always starting with theory. So what do you know exists in the literature? What have other researchers done? What have they hypothesized? What have they claimed as a theory? So what is the theory you're going to use? And what are the gaps in the theory that you find to be interesting that you want to fill? So usually your research question is some sort of solution to some sort of gap in the knowledge. So it could either be, at least the way my advisor talks about it, like there's a gap in our knowledge base. So we just don't know about this one particular thing in this context. So that's a knowledge gap. It can also be a method gap. So we know that this exists, this whatever hypothetical phenomenon exists in this way. It's been studied in this way with these measures. There's a gap because here's some other measure or here's some other method that's really important in this context, and that hasn't been studied. So as a researcher, really interested in filling that method gap. And whatever method I'm proposing, I'm saying is very important and has relevance for child psychology in this field. So you're always filling a gap. And you're not just, you could replicate studies if that's your goal, in which case you would say, like, this is a replication study where I'm just redoing what someone else did. But that's not the majority of research. The majority of research is trying to fill a gap. And again, your gap, you're not going to go know the gaps until you've read the literature. So knowing what the theories are. Once you know what gap you want to fill, as you're thinking about, well, that's a gap. I think I can fill that. I know one particular way of doing that. You're in that phase already generating a hypothesis. So, what do you want to test, and what do you think the potential outcome is going to be? So, hypothesis is a testable and falsifiable statement predicting what will happen in a study. So, the idea is yes, ideally, you want your research to like support your hypothesis. But as a good researcher, we also need to be able to disprove it. So we always use a null hypothesis do, which is that there's no difference in what we predicted. So if I think that there's going to be, let's say I'm testing like a therapeutic intervention for kids, my hypothesis would be this intervention has like changes child behavior outcomes from baseline to the start of the intervention and up to like 18 months after the intervention. So I'm going to be testing the difference between child behavior outcomes between baseline and 18-month. That's what I hope to happen. I hope that there's going to be change. I hope that behaviors are going to go down. But I also am testing the null, which is that there is no difference from baseline to 18-month. There's the difference is zero. So I feel like in this context, I think all you need to know is a hypothesis and a null hypothesis. If you do become interested in research, though, and you want to join a lab, I think just remembering that the null also exists, and that's what we're trying to test in the statistical context. Any questions about that part, null and the hypothesis, and then the gap stuff? Okay. Once you have your hypothesis, you go out and you collect your data. So it could be you're running an intervention, you need to recruit all your people. If it's an intervention for children 3 to 5, that's your inclusion criteria. They have to have, I don't know, like a diagnosis from a primary care. So you need to have a lot of time to do your recruitment, to actually develop like your full sample, and then to start giving the intervention. So that takes time to do that and then collect the data. Once you have all your data, you analyze it. So before you go from collecting to analyzing, you have to clean your data. You have to make sure that if you have any missing data from people. So sometimes participants will have like a really full interview battery. So they'll have an interview, they'll have like 50 different questionnaires that they have to fill out. Understandably, a lot of times people skip things. And so you have to deal with that as the researcher cleaning that data. So are you going to leave the data as missing? Are you going to use a statistical method to impute the data? That there's a lot of work that goes into the analyzing data stage. And in fact, like that's a job in and of itself outside of like undergrad, like that is a data management, like data technician job, which is solely just to work at this stage. And then once you have your data, you sit with it and you interpret your findings. So what does my data say? What are my results? And once you've actually cleaned it, you have like the statistical results in and of itself, then you're putting it into the context of what your hypothesis was to begin with. What's the literature that I was looking at? Is what I'm saying confirming what I thought was true based on the literature? So if my intervention, like I said, was 3 to 5 year olds um, trying to treat behavioral problems, and my hypothesis was that from baseline to 18 months that the problems are going to go down, my theoretical orientation was that that intervention is going to work because it utilizes XYZ, which I know in the literature, like theoretically, that makes a lot of sense. That thing that they talk about is what I'm using in my intervention. So I think that's why this should work. If I find out at this stage, analyzing data stage, that, ooh, actually there was no change from baseline to 18 months, statistically, the behaviors really didn't change that much. I have to go back and think about why would that be, even though the research says this. And so at the end of every research paper, you should see results, discussion, and within a discussion, you'll see like a limitation section. So you'll see someone saying, again, here's why I thought this, but clearly my research shows that it does not meet what I thought. And so here are some positive alternatives for why that might be. Could be things like there are some like statistical weaknesses, like your sample size wasn't big enough. Could be like there wasn't enough variability in your sample. Could also be like my intervention was flawed. I was relying on students to administer it, and there was some variability between the students. One student administered it this way, another student administered it this way. So that is another possible reason that you might have differences in your data. And then once you have that, ideally or theoretically, at some point you're retesting it or you're adding in whatever new knowledge you've integrated. Okay. I'm going to move on unless you all ask if you have any questions. Okay. I'm going to fly by this part. So this is designing the study, is that early phase. If we look at that graphic, it's right at the generating your hypothesis stage. So you want to design your study. You need to figure out what your variables are. Is your variable the intervention? Is it the child behavior outcome? Is it mom's own psychopathology? So you want to know what your variables are, and you need to be able to measure it precisely or as best as you can. So that's what this operationalizing means. It's finding a way to have a measurable outcome for a particular variable. So if you're measuring stress, are you going to pick stress in the context of heart rate, or are you conceptualizing it in the context of cortisol, which is a hormone response, in which case heart rate is measured very differently than your secretion of cortisol. So that's like a physiological thing. You might need to use certain like equipment that you wouldn't use for heart rate monitoring. If you're measuring aggression, are you using it in the context of a parent's report of how aggressive their child is, or are you being observational? Are you going to go into the playground and are you going to observe toddlers and see how many times they're pushing, how many times they're shoving somebody? That's very different. And so you would need to operationalize that. Depending on what you operationalize, you want to discern which one is your independent variable. So what are you trying to change? What are you testing? What's your dependent variable? So what are you hoping is the resulting variable? And then are you going to add in any other third variable, which we talked about last week? So are you going to have any mediators or moderators based on your theoretical orientation? Select research participants. So we talked about that. So in the intervention example, if I need 3 to 5-year-olds with the primary care diagnosis of XYZ disorder, I need to find a way to recruit that sample. I need to perhaps go to the primary care clinics and ask them, can I put my flyer in your clinic? I might need to post an ad on like Instagram or Facebook or wherever you think parents are. Not only would I post that to my personal, but maybe I'll go join like a parenting group for toddlers and maybe I'll post it in that forum. So you need to be really clear on what your inclusion criteria is. So who do you want in the sample? And you want to be really particular about what are your exclusion criteria. If you meet this means you cannot participate in my study. So for example, if my inclusion is 3 to 5-year-olds, an inclusion criteria might be anyone 6 years, 0 months and up cannot participate in my study. And so that's a screening criterion that you might have. The other thing here is you have to get IRB approval. So that's your human ethics committee, which we'll talk about later on. So you might have an idea that I think it would be really helpful if I could go to schools and get 3 to 5-year-olds at these preschools because that's where they go every day. It makes a lot of sense to go there. IRB, which is your human ethics committee, might say, that might be coercive. That's their place of education. Parents are paying a lot of money to go there. Like that might not be ethical. And they might give XYZ reasons, in which case you need to go back and figure out an alternative way if that's deemed unethical or coercive in any way. Same thing with selecting your measures and instruments. You need to decide what's going to actually measure your construct of interest. So like I said, is it heart rate or is it watching a kid shove somebody on the playground? Depending on what your instrument is, you have to think about how many instruments am I using? So how many surveys am I going to ask this person to fill out? How long do I need to observe this kid in the playground? Is 5 minutes enough of a sample or does it need to be an hour? Depending on that, you want to think about how long is your battery, how long is the actual data collection. Especially for self-report surveys, IRB will say that's too long and you're only paying them, I don't know, $10. That there's a huge disparity in a $10 compensation fee versus they took 3 to 4 hours to complete this survey. That seems not that doesn't benefit the participant. So IRB might say you need to increase your compensation. So that might be because they looked at your measure battery and they might have said that's really, really long and that doesn't make a lot of sense. So that's another thing you have to be thoughtful of. Strong psychometric properties, we'll talk about that later. It's just how good or evidence-based are your instruments that you're using. Okay, then you'll collect your data, which we talked about. People often underestimate how long it takes to collect data. So intervention data. So I've been involved in a lot of like parent-child interventions. It's not going to take a month. Like a month can be like the very early stage of just recruitment in and of itself. So a lot of times you'll have an intervention for at least 6 months, usually a year, and then you want to have a lot of follow-up assessments. So you can't really do anything if you want to be able to test somebody at 18 months follow-up. I have to wait for the recruitment, the data collection, the intervention to actually take a year, and then for them to hit their 18-month follow-up point. So collecting data can take years. Same thing with analyzing data and interpreting your data. So like I said, you want to clean it, which is like dealing with missing data, maybe your scoring metrics are wrong. Cleaning it up so that you can actually score it based on your measure. So again, if I was looking at child behavior outcomes for those 3 to 5-year-olds, there's a particular survey that I might give the parent because a 3-year-old is not able to write and read the survey. And so I will give them the survey, I'll score it based on their scoring metrics. They'll give you like raw scores, like these are the total behavior problems, these are the internalizing problems. So whatever the scoring metrics are, I'll use that. And then I will statistically use whatever my test is going to be. And then once I get to the results section, I need to decide, did this support my hypothesis or did this not support it, in which case that support question is really, is your result statistically significant? So there's a p-value that you're going to look at. It's a statistical value, which basically tells you the probability of getting your result if the null hypothesis was true. So you want it to be like more than chance that your result would happen in nature theoretically, even if the null hypothesis was true. So the convention we use is p less than 0.05. That's going to change depending on your field. So certain science fields might say that's too large. They might change it to 0.01 or 0.1. We do that too in our field, so it depends on your sample size. There's different statistical reasons to change that p-value, but typically less than 0.05. So if you get a result that says your intervention changed behavior outcomes in a child, here's the number, but the p-value is 0.75, that is not less than 0.05, in which case we cannot reject the null. We can't say our hypothesis is supported. We have to say, ooh, this result was not statistically significant. So according to my result of this particular study, I can't say that my hypothesis that intervention A works from baseline to 18 months for this population that I worked with. You're going to ask yourself, even though it's not statistically significant, does it have any clinical significance? And maybe it does. Those are things like, I, for the first time, developed this intervention, and it integrates this one thing that all the research says is really important. And I know that no other intervention has done that. Even though my results are not statistically significant, it's clinically significant because it integrates this really important thing that no one else has done. And so future research should really try to integrate my intervention. So it could have clinical significance. It does matter, and it should be studied beyond my own study. And then once you've decided this is your interpretation stage, you report your results in whatever forum. So if it's a paper, you're writing it in your discussion section. If it's a presentation, you're still writing it in the discussion section, but in a more concise way in a PowerPoint. And one of the things you'll say is not only that your results are significant or not significant, or your hypothesis was supported or not supported, you're also going to explain how does this study contribute to the research or the literature, even if it wasn't statistically significant. And you'll talk about what your study's limitations are. So the onus is always on you as the researcher to identify the strengths and the limitations. Because in this field, the idea is that all research should be replicable. It should be transparent. Any researcher should be able to follow your results section or your methods section and replicate your data, replicate your research, because we want to keep transparency and integrity in the field. So that's why the onus is on you as the researcher to say, here are the strengths and here are the limitations. So because I have XYZ limitations, every future study should, my sample was too small. Your sample, if you're going to replicate my study, should be twice as large. I ran the statistical test that told me your sample needs to be at least 100 participants. So you are already generating alternatives and possible ways that someone else could replicate your study. Does that make sense? Okay. Oh, I think you're about to say yes. If not, you can ping yourself. Okay, let's talk about different types of measurement. So remember, going back to your selecting measure/instrument stage, you have to decide, what are you going to use? So are you going to do direct observation, like the example I gave you with watching a toddler in a playground and counting how many times they shove somebody? That's a direct observation. Are you doing a standardized test? So a lot of times in neuropsych evaluations, especially for kids, you will, well, not especially for kids, any neuropsych evaluation, you're typically including some sort of intelligence or IQ test. All IQ tests that we use are standardized. So if you remember that normal distribution curve that we looked at, that's specifically for intelligence testing. So we expect that for intelligence, everyone follows within this normal distribution. So that's the thick part of the curve. Anybody that falls outside of that curve is where we might say, ooh, they have really, really, really low intelligence. That might point to intellectual disability. Or on the opposite, they're on this really, really high side. Wow, this person has really high intelligence, really high IQ. These are some protective factors that they might have. So the standardized tests we typically use for intelligence and things like that. Bio and physiological tests are the things like heart rate that we talked about. If you were testing like cortisol level, that's another physiological test. You might even do genetic testing. Oh, that's down there. But the other thing that I thought of was anything with like saliva, blood, inflammatory markers. So you might be looking at inflammation. That's also an physiological test. Self-rating scales are your own report of what's going on for you. So any survey that I give you that you have to report on yourself would be self-rating. Informant would be someone else is reporting on you. So often with little kids, we have the parent report on the child. And then genetic methods are that thing I was talking about earlier. So I might take a sample and look at some genetic markers. I just thought of another one under physiological tests. I was in a lab before UH that was looking at parent-child relationships, and they were taking stool samples because they wanted to look at some like inflammatory marker in the stool. And so that was it was funded research, so it was really interesting, but people might collect stool sometimes. Okay, this is that thing earlier where I put a little star where I said strong psychometric properties. So you're not just coming up with measures on your own, and you're not just randomly selecting measures that sound good. So any measures that you're choosing for your study have to have an evidence base for it, and there needs to be a strong rationale for why you're picking it. So your measures need to be valid and reliable. Do you guys already know the difference between validity and reliability? Maybe you've heard it before. Okay. Well, then I'll cover it. So validity is, does your test, or in this case, does your measure actually assess the one thing that you're talking about? Is it actually measuring the construct that you're interested in? So your measure should be an accurate indicator of whatever your variable of interest is. So when we talked about, okay, like the toddlers, the 3 to 5 year olds, and we're looking at aggression. If I start measuring um, the how often the parent reads to the child, unless I have some strong theoretical reason to suggest that reading at nighttime with the parent has some sort of relationship to child aggression, it wouldn't really make sense to measure that. So unless I say that could be a third variable that's related to this aggression index that I'm curious about, it doesn't really make sense to measure, like throw things at the wall and say, let's just measure it. So unless you have strong theoretical reason and you think that it's actually a measure of what you're interested in, it doesn't make sense. And it's a waste of your participants' time to have them answer things that don't have any real relevance to your construct of interest. Um, so validity plays a role because if you're not actually using a measure that's supposed to measure what you're talking about, your measure is not valid in this particular study. It's not actually an accurate way of operationalizing your variable of interest. There's different types of validity. There's more than this actually. So there's internal validity, there's face validity, content validity, predictive, construct, external, concurrent. I can't remember if I have a question on this in the exam. I probably will remove it, but I do think it's important to know in general what's validity and knowing that there are different types. Okay. Well, okay. Let's look at construct, concurrent, and any of these others. Internal validity is your independent variable that you're interested in testing actually causing the changes that you see in your dependent variable? If it's not, you probably haven't operationalized your independent variable properly, or there might be some third variable that's more responsible for this relationship. So does your study actually have internal validity? Is it actually testing what you're supposed to be testing? External validity is, are your research findings actually applicable to the real world? So the more that you're trying to make internal validity stronger, oftentimes the caveat is that you risk losing some of your external validity. So it makes sense that the more tight that you make your study to increase internal validity, the less realistic it is that that actually happens in real life in nature. So If you have like a really stale room, it's all white, you have test tubes and people in like, like PPE to be all covered in your particular experiment, that's not often what you're going to walk into in real life. So that's how external validity goes down. Content validity is, does it cover the appropriate content? So is it too narrow, my measure? Or is it capturing enough of what I'm interested in? Convergent validity or concurrent is, do results align with other measures of the same construct? So if I am interested in developing a new measure, so let's say I came up with my own questions, I think my survey is a good survey of parenting, I need to be able to say that my parenting measure aligns with other established parenting measures. So there's something like the MAPS, there's something like, what's her name? The one who teaches about authoritarian, authoritative, permissive, and can't remember the fourth parenting style. So I know that that's a really clear established measure. I need to make sure that my new measure actually lines up with those other ones. So that's convergent validity. And then construct validity is, does this test measure the correct construct? So am I measuring the right thing? Okay, so with that in mind, why is this one on the left, a self-report test of depression is highly correlated with an observational measure of depression? Why is that considered convergent validity? Oh no. Do you remember what convergent is? You want me to go over convergent again? Or at least, or if you give you the answer? You can ask for a lifeline. Okay, I'll give you guys this one. So a self-report test of depression is highly correlated with an observational measure of depression. So I might give the PHQ, so the patient health questionnaire, which is a brief self-report measure of depression. I think it's 9 items and it quickly goes through the criteria for major depressive disorder in the DSM. I might ask you to fill that out, so that's a self-report test. And I also know that if I have you sit down in an observational room and I watch you and I have specific criteria that I think matches to depression, and those two tests, I've given them both to you and they have high correlation with one another. So maybe they're 0.5 correlation or higher, ideally 0.75 or higher. To me, that tells them that they're highly correlated. So that tells me there's good convergent validity because two separate measures of the same construct of interest have high correlation. If my self-report had really low correlation with my observational measure, there's a like a as this one goes up, the other one goes down. That might be concerning because my self-report test that I just tried to make up is not mapping onto the observational measure. And that might tell me I might not actually be measuring depression as I thought it was. So if I have low indicators of convergent validity, I might need to change something in my study to increase convergent validity. I'm going to skip construct validity. Any explanations for why the SAT is highly correlated with university academic performance, how that's an example of predictive validity? Any thoughts?
Will you repeat the question, please?
Yes. So why is this example over here a good example of predictive validity? So how does it make sense that the SAT would be highly correlated with later on your university, so undergrad academic performance?
Because they work in the same field where one, it's funny enough they use the word correlated, but one is connected to the other.
Yeah, exactly. So predictive validity is the idea that whatever one measure is going to be predictive of some other later outcome. So theoretically, the reason why this SAT exists and the ACT exists is because there's some research that shows that your SAT score, which you have to take when you're in high school, is predictive and highly correlated with whatever your GPA is as an undergrad student. So yeah, that's exactly right. It's example of predictive validity. Um, I don't know how outdated this SAT statistic is, but that's theoretically why they even have it. Why do we even have high school level measures of academic performance? It's because people think that it's going to predict how you're actually going to perform in college later on. And so that might be a good example or a good criterion that your university like committee might want to look at when they're determining if they want to take you as a high school student. Okay, good job. Okay. Um, so that was validity, right? So we want to make sure, is the thing measuring what I think it is? And how does it hold up in terms of convergent, construct, predictive validity, all those types of things. So how accurate is my measure? That's different than reliability, which is also really important, which measures how consistent is your measure actually measuring the thing that you think it is. So is it actually measuring it every time that you give that assessment? If it's not consistent, that might tell me that my assessment measure is not reliable because I can't rely on it to give me the same range of responses every single time in that same circumstance. So there's different types of test reliability. So there's test retest reliability, which would be I gave this one measure at time point one, and then I gave it again at time point two. Each time that I gave it under the same conditions, my my result from each time is somewhat similar. That would show good test retest reliability. Alternate form reliability is literally what it sounds like. So I have form A and I have form B, which are theoretically similar. Like the questions might be worded differently, they might be ordered differently, but it's measuring the same construct. So if form A and form B have high reliability, these two things would be measuring consistently each time that you give it to them. Item reliability has to do with the specific items in the survey or the measure you're giving. And then inter-rater or inter-observational reliability has to do with people who are rating some sort of observational task. So the best example I can give of this last one would be I'm familiar with having like a parent and a child like interact with like in a free form play idea. So have the parent and the child come sit in this observational room. There are a lot of toys and just watch them. So there are no instructions, just play as you would. I might have them do that because I'm testing some sort of observational coding scheme that I have. I have a coding scheme that's going to measure parenting sensitivity, warmth, harsh behavior with the child in a free play task. So as I'm watching them, I'm going to be scoring my coding scheme. So I might have from 0 to 5, I think you need to score sensitivity. 0 to 5, I think you need to measure warmth, and then harsh behavior. So that's what I would be doing as the rater, but we can't go off of just my coding scheme. That's because we are fallible. So I could be measuring this one person, and then 10 days later, I'm sick, but I'm still measuring it. My scores might change just because it's a different day, even though I'm the same person. Maybe I'm not, it's just some other reason that I might not be able to consistently give the same response. Let's say we have 1,000 families that we need to rate. That's a lot of people for just one person, for just me, in which case I might add on more raters onto my team. So I might say there's 5 people now on my team. All of us are responsible for measuring those 1,000 participants, but how can we ensure that my rating is going to be similar across all 4 additional raters? For that situation, we need to calculate inter-rater reliability, or IRR. So I'll take my measurement of, let's say, 20 people, and we have the same exact people. All 4 other people measure the same same 20 families, and we compare across all 5 people. What does the rating look like? So if I have, I don't know, like high reliability with rater 2, that means that we can consistently ensure that my rating and that second person rates similarly. If I have low inter-rater reliability with rater 3, that means that when that person rates something, you cannot consistently believe that I will rate something similar. So it wouldn't make sense to include me and rater 3 if we have low rater interreliability, because their measurement of the sample is not going to be the same as mine. And if you include it, we're going to have huge variability, and we may not actually be measuring the parenting constructs that we're interested in. So we can either work to improve reliability. We might say, Rater 3 and Bree, you guys need to continue adding more people into your sample. I want you to increase your reliability. You just need to keep scoring and scoring, converse with one another, see why are you so disparate? So we can work to increase, or we could just say Rater 3 doesn't make sense. Let's take them out. They're not going to be a rater. Let's only keep the raters who have high reliability. Does that make sense? Or I don't know if you're all familiar with like coding scheme ideas and like psych research. Okay. Another thing you can do to ensure with inter-rater reliability that you are really like accurately measuring what they would normally test or rate, you can make sure that your observers are blind. So make sure you're not telling them of the condition. So again, in that example, if I have a parent and child in a free play task, I might have put them through an intervention. I might have 50 of 100 people went through the intervention condition. The other 50 people were in the control. They never got the intervention. They just were treatment as usual. If I tell the raters who are going to watch that free play task that, hey, those 50 people that you just scored, those are going to be the people that went through the intervention, it may bias the person and they may want to score parenting sensitivity higher because they know theoretically, I would hope the intervention works. Versus if they measured the other 50 and they had no knowledge of whether or not they attended the intervention or not, theoretically it should be equal across. They should be able to measure based on the coding scheme, not based on the condition that they think the person's in. Okay, if you don't have any questions, I will move on. I'm going to skip this page. So these were just examples of different types of reliability with a graphic. Different examples of reliable and valid versus conditions where there are not equal. So this one on the far left is considered reliable but not valid because if we're thinking validity equals accuracy, and we think accuracy is hitting the bullseye, there's nothing in the center. So we were not accurate at all. So there's no validity, but all 5 times that I threw the dart, they generally landed in the same area. So that tells me there's consistency. So that means there's reliability, but not validity. Same thing here, nothing hits the bullseye, nothing even close. So there's no validity or accuracy. But each time I've thrown it, they all cluster in this area. So there's consistency, which means there's reliability. Here, there's both because we hit the bullseye, which means there's accuracy or validity. And each time we've hit it, it's consistent across all 5 times that we've done it. So that's reliable. And then the far right, there's nothing. There's no reliability or validity because nothing hits the bullseye and nothing clusters together. Everything is spread out. So nothing is consistent or reliable. I don't think it's that important to know the different research designs. Just know that there are different types of designs that we might choose based on what we're testing. So if I'm choosing descriptive, it's because I want to describe some sort of phenomena. If I'm doing something that's non-experimental, I'm not really interested in like obtaining research participants. Maybe I'm just looking at statistically what am I expecting to see. Experimental is what we're probably most familiar with, which means we have some sort of variable or intervention that we think is going to change something. So we want to test it out. Case studies are different because it's not that there's an intervention that you're trying to test, it's that you're studying something as it exists. So a lot of times you'll see case studies in psych research on like a specific population or a specific person. So I might be interested in this one individual because they have a unique presentation of autism, PTSD, personality disorder. They might have something really interesting. And let's say I'm trying out a specific therapy modality. I might write a case study on that participant because I think it's really unique and I want to tell people how I treated this person. So here are examples of some that I pulled out. So here's CBT for an adolescent female presenting with misophonia. That's a case example. Here's another one, enhancing the capacity for optimal social and personality function through this particular intervention, another case illustration. I use this one on the left. So I'm going to go back. Why do we even care about case designs if it's not using a large sample? Why do we care if it's just one individual? A lot of times, the thing that you're studying in a case study is not something that's previously been done. And so you're kind of like trying to figure out what to do. And so these case studies are helpful for helping you to generalize a little bit, but just knowing, there's not yet a large grounding or standing for this run finding, but we think that this one case study could be helpful for filling whatever gap I'm trying to fill. So I'm going back to this one on the left because I last year worked with someone who was like 26, maybe 24, 26, is a male, um, is on the spectrum and also has misophonia. Misophonia, are you all familiar with that? If not, so misophonia is not recognized in the DSM, but it's thought of as like a condition where you have like distress when there are certain sounds that you hear that are distressing to you. So it's interesting because it's not in the DSM. So it's not something we recognize yet as a psychological disorder. But a lot of people in the who are audiologists in the primary care field will talk colloquially about misophonia. And so there's this client that I had worked with who came in because he has autism, his higher functioning. But one of the things that was really impairing for him day to day was misophonia. And so for him, not only was he in his 20s, not only was he on the spectrum, but he also had this misophonia condition that he really wanted to treat. The problem is that there's not yet any evidence-based intervention for misophonia with autism um, of his presentation. And he was also virtual. So he lived really far. It was really hard to see him in person, which is ideal if you were going to work with misophonia. So, how else were we going to do therapy virtually and testing out these different sounds that are distressing to him? So, before I tried anything, so I knew theoretically, like when I think of misophonia, I kind of think of not anxiety, but I think of kind of those like OCD, anxiety, those kind of responses. And I know the evidence-based treatment generally are exposures. I think that would be the same for misophonia, but I don't know, so I'm going to check. So I tried to do a search. There was really not anything out there. And so I was finding like a few case studies like this, where would be an adolescent with autism, or maybe not with autism, but they were trying to treat the misophonia through some sort of virtual telehealth. And so this actually was super helpful for me because they wrote what the presenting information was for this teen that they were working with. They wrote what the intake information was about, and then they wrote, I think it was session by session, like this is what we did in every session. Here's the survey we administered every so often to test like how the symptoms were going down or going up. They also talked about like specific techniques that they use that was meant to be helpful for virtual therapy versus in person. And so I used this case study just to help like structure what my therapy sessions were going to be like. And some of the strategies that they used for the virtual portion were super helpful for me because my client was virtual and it was really difficult to try to figure out like how am I going to elicit thunder. I can't like naturally ask thunder to come. So like I have to find videos, um, like dogs barking. Like I don't where I was in a private practice, so I have nowhere around me any dogs. So I need him to go step outside and his neighbor had a dog. So I need you to be by there, or I need to find videos of like dogs barking on YouTube. So I say this because clinically, case studies can be really helpful. But just know that there's a case study because there's not much out there in terms of empirical literature. It's a case study so that you can help give yourself a starting point. Okay, any questions about that? I might just end here and talk about a couple things for next week. Okay, no questions. Okay, so we have like 4 minutes. I think what I would like you guys to do, so next week we're technically supposed to start with chapter 5, which is looking at classification and assessment. So this is getting closer to how do we actually diagnose um, specific disorders. why is there controversy in the field about why the current classification systems don't always work. So we'll get to chapter 5 next week, and then the exam only covers chapter 1 through chapter 5. So let me see if it's on. I'm just going to go to the end of the PowerPoint so you guys can see that. Okay. I don't know how to make it screen share again. There's a weekly to-do list. So today is Friday. We're done with chapter 4. Just scroll through the rest. I don't really think you need like a voiceover or anything like that. I think it's pretty self-explanatory. So there's only like maybe 8 more slides, well, 10 or so slides left, and then that's it for chapter 4. So if you can, just read the rest of it. Next week we'll start with chapter 5, and then we will be done. And then we'll have a review afterwards for the exam. And then just a reminder that the syllabus quiz closes on Sunday if you do want to take it. Any questions about what's next or what you're supposed to do? No? Okay. Well, send me a message if, oh, 2 questions. Thank you. Um, okay. Can something be, okay, this is, I'm not related to an announcement or anything. Feel free to put it in the chat. Yeah, could something be valid but not reliable, or is that tied together? No, so there are examples where something can be valid. So it might be accurately, theoretically testing what you want it to test, but it may not be consistent. So every 10 administrations, it may not consistently be testing that. Um, so I can't think of like a specific measure right now, but I feel like so that example actually of like that coding scheme that I gave, where you might have different raters administering that same measure, maybe that coding scheme is actually valid. It's testing the thing you want it to test, but the people who are administering it inconsistently get different scores, in which case there wouldn't be reliable administrations. So that would be an example of the actual coding scheme, the measure is valid, but it's non-reliable because the raters who are doing it, there's like different interfering factors that might make it unreliable. But good question. Anything else? Oh, okay, the second question was, how do we change what is valid or not? So I believe if something is valid, but everything and everywhere is reliable for something else, why change the validity? Yeah, that's a good question. So on that slide where I talked about internal and external validity, oftentimes you're sacrificing one or the other. So if something is not valid, it might not. So ideally, you're trying to change the measure so that you're getting more precise. So let's say I'm trying to measure this really specific thing, but my measure is like very broad. And so every time I administer it, I'm not actually testing the thing I want to test. I might have to change, if it's a survey, I might have to change the questions to become more precise, in which case, after I have fixed it, I've refined it, it may increase the validity, not only internally, but externally, because I'm actually measuring the thing I want to measure. Um, and then so yeah, so validity can still not exist and there can still be reliability at the same time. So ideally you're trying to like modify both sides so that you're getting something as equal as possible. But it's not perfect. So a lot of times you'll read studies and it'll say in this sample that I studied, reliability was really high, and yet like my results weren't what I expected. And it could be actually we didn't measure the thing we wanted to, validity was low. So that could be it's possible that you might have that. Um, yeah, good question. All right. If anyone has any other questions, I'll hang on for a couple minutes, but otherwise you are all free to go and I'll see you all on Monday. Thank you. You too. Have a good weekend. Okay, I'm gonna end the call. I don't know if you all have questions, but if you do, feel free to send me a message on Canvas.